Bronchoscopy is an endoscopic procedure that visualizes the tracheobronchial tree by placing an optical instrument inside the lung. The value of bronchoscopy has really grown in its diagnostic and therapeutic capacity over the last 2 decades, and the clinician needs to be available not only about the technology, and also he should be well aware of the associated clinical application of bronchoscopy. So, what are the types of bronchoscopy? The rigid bronchoscopy came into existence long back, and that has been still prevalent, and it has re-emerged as a therapeutic scope for most of the procedure. The flexible bronchoscope, which is the commonest bronchoscope used, and the third is a virtual bronchoscopy. The rigid bronchoscopy consists of a hollow metal tube with a light on its distal end. Tube is inserted orally under GA and then passed between the vocal cord and the trachea. Large lumen facilitates clearing of the secretions, the debris, and also it helps you to do the interventional procedure easily as compared to the flexible bronchoscope. The indications of rigid bronchoscopy, I think foreign body we have been removing preferably with the rigid scopes for many years. So, it still remains the indications for removing the foreign body in pediatric as well as the elderly age group. Then it has a role in a life-threatening central airway obstruction. It has a role to perform tracheoplasty or a bronchoplasty in a patient who has a tracheal stenosis or a bronchial stenosis. Tumor resection with central airway obstruction patients who are unfit for surgery. It is also used for stent replacements for long-term management of stenosis patients, and of course, a patient with a massive hemoptysis you cannot control with any other scope. You have to use the rigid scopy. The flexible bronchoscope, which is also known as the standard white light bronchoscopy, it is typically performed using the conscious sedation and is small, more flexible piece of equipment, and that permits the access to the lower airways up to the third order of the bronchi. But now with the newer scope, it is possible to see even beyond the third generation of the bronchi. As I said, it is the most common type of bronchoscopy. It contains optical fibers or a small camera at the tip of the bronchoscope to transmit images, a working channel and a light source which together allow the operator to visualize the endobronchial tree. This is a cartoon showing the various parts of the bronchoscope. It has a control panel which has an eyepiece, a diopter ring to control the focusing. It has a place for suction control. It has a control lever which allows the tip of the bronchoscope to be moved up and down. It has a port for doing procedures, and then it is connected to the suction channel, which is connected with the tube to the suction apparatus. Then it has an inserting tube which is of different length, and the tip of this inserting tube only bends up and down. It does not move on the sides, it only moves in one direction. So, you have to use the wrist to move it on different sides. Then it has a universal cord which is connected to the light source to transmit light to see inside the airways. And this is a picture of a video scope which I said has a camera at its tip and it transmits images. The control panel more or less is the same. You have a suction channel, you have a control lever, you have a port to take biopsy specimens or other specimens through that port, and it is connected to the processor, or which is the light source as well as the image processor. Then there is a new scope which has come, which is called the ultra thin bronchoscopy. Ultra thin bronchoscopy is performed with a flexible bronchoscope that has an external diameter of about 2.8 millimeter. It's smaller than the regular scope, and allows the examination beyond the third generations of airways. It can be used to obtain biopsy material because the suction channel or the channel is more than 1.7 millimeters, through which you can pass the biopsy forceps to obtain the specimens from the lower airways. Now, it can be combined with the virtual navigation bronchoscopy to obtain the sample from the peripheral nodules or masses or lesions with the help of the ultra-thin bronchoscope. The third type of bronchoscopy is the virtual bronchoscopy. It doesn't use any instrument. It is a non-invasive form of bronchoscopy. It's not an endoscopic procedure, rather than an imaging modality that reconstructs the airways in a three-dimensional manner, producing the images that are similar to those visualized during the invasive bronchoscopy. Unlike flexible and rigid bronchoscopy, it cannot be used to acquire samples. Its use is limited to the center with expertise. It can be combined with a virtual navigation bronchoscopy along with ultra-thin bronchoscopes to obtain the sample from the lower airways. What can you do is, the first an airway path is planned to the target lesion using a computerized three-dimensional reconstruction of the patient computerized tomographic chest images, and then an ultra-thin bronchoscope is inserted and passed through the airways, following the virtual guidance by matching the airway seen on the 3D with the real images obtained through the ultra-thin bronchoscope. As you can see, on one panel is the virtual navigation, the other is the actual bronchoscopy with the ultra-thin bronchoscope, and the third you can combine it with the fluoroscopy to see that you are approaching the right lesion. And there are other software also to help you to guide the navigation if you are using the ultra-thin bronchoscope. Now, coming on to the indications of bronchoscopy, where the flexible bronchoscopy is indicated. I am basically going to talk more about the flexible bronchoscopy. As I said, that the bronchoscope has a diagnostic as well as therapeutic indications. Among the diagnostic indication, three very important indications are evaluation of pneumonia or infiltrate of unclear etiology, persistent atelectasis, and assessment of diffuse lung disease. The evaluation of pneumonia or infiltrate can help you to obtain specimen if you are not able to diagnose by other means, like a patient who's got a fever, he's got a pulmonary infiltrates on the chest diagrams, and he's not able to produce any sputum. So bronchoscopy can be used in that individual to obtain the uncontaminated lower respiratory tract secretions. You can do a lavage and or bronchial washing, and even you can do a biopsy in these individuals to obtain specimens. And it is extremely useful in patients who are immunocompromised. These patients most of the times do not produce sputum, and it is important to find out the kind of organism they are suffering from. So you can use the bronchoscope to obtain uncontaminated secretions from the lower airways, which can be sent for the opportunistic infections like the PCP, fungal infections, Aspergillus, etc. And the immunocompromised host is increasing because we are using a lot of steroids. We have increased population who are on chemotherapy. A lot of patients are being transplanted, HIV patients. So because of the increase in population of these, there are patients who do get pulmonary infections, and it is important to diagnose correctly in these patients. Then the second indication is a persistent atelectasis. Patient has an atelectasis which is not responding to the treatment, and repeated chest diagrams are showing that atelectasis is persisting. Patient may be all right or patient may be symptomatic. The bronchoscopy could be very useful to find out the reason for persistent atelectasis in these individuals. It could be a malignancy, it could be endobronchial obstruction, or it could be a foreign body, or it could be a mucus plug. So bronchoscopy can help you to diagnose, or it could be a stenosis. So bronchoscopy can help you to diagnose what is the reason of persistent atelectasis. Then the third is a assessment of diffuse lung diseases. It's a very common nowadays to see people suffering from a variety of diffuse lung disease. It's a very large number, and many a times it's not possible to diagnose what is the exact type of etiology you are dealing with. The bronchoscopy can help you to differentiate whether it is infectious or non-infectious by taking out the samples, which can be sent for various tests, and also you can do a transbronchial lung biopsy in these individuals to diagnose what is the kind of the diffuse lung disease the patient has. It can help you to diagnose a lot of diseases like sarcoidosis, the malignancy, the lymphatic carcinomatosis, eosinophilic pneumonia. The transbronchial biopsy is useful in many of the patients who have the diffuse lung diseases. Then the other indication where you use bronchoscopy is a investigation of a suspected neoplasm, which can present in a variety of presentations. It could be a centrally located masses or nodules. A bronchoscopy is a very reasonable approach to obtain the samples to evaluate the central airways with a bronchoscope, which you had seen a mass or a suspected nodule on the chest diagram or a CT scan. Diagnostic specimen can be collected for cytopathological examination, washing, brushing, ball and biopsy in these patients. You can also find out if it is not visible in the airways. You can find out the compression by the mass on the airways, and you can obtain nowadays the TBNA, the transbronchial needle aspiration, or you can do an endobronchial ultrasound to take a specimen from these masses, which can not only be sent for cytopathology but also for immunohistopathology. Flexible bronchoscopy is much less useful for a peripheral small nodules, and now it is possible to obtain samples from the peripheral nodules with the help of the flexible bronchoscope. As I said, the ultra thin bronchoscope, which is an outer diameter, varies from 2.8 to 3.5 millimeter in diameters, and it can reach beyond the third generation of bronchi, and it has a channel which is about 1.7 millimeters, so it can help you to obtain the biopsy. But if you are not able to see the lesion with ultra thin bronchoscope, you can use the fluoroscopic guidance to guide you, or you can use an electromagnetic navigation guidance, or a virtual navigation guidance as I discussed, or you can use the radial probe ultrasound guidance through the ultra thin bronchoscope combined with the fluoroscopy to reach the target lesion. So there are various options now to reach the peripheral masses. One is that you combine your ultra thin bronchoscope with a simple fluoroscopy to reach the peripheral lesion. Then you can combine the virtual navigation bronchoscopy, or you can combine it with the electromagnetic navigation bronchoscopy, or a radial probe ultrasound guidance to reach the peripheral lesion. Then mediastinal lymphadenopathy or masses. The carinal and paratracheals after the transbronchial needle aspiration through bronchoscope had never been a problem. But now with the advent of the endobronchial ultrasound, you can not only reach the various mediastinal lymph node and masses, but also it is possible now to stage lung cancer. And endobronchial ultrasound is less invasive alternative in staging of lung cancer than many others. Then there are other indications like persistent atelectasis, where again you suspect malignancy, unexplained pleural effusions, unexplained vocal cord paralysis, stridor, localized monophonic wheeze. Less common presentation, but they can be presentation of malignancy, and bronchoscopy should be done to rule out malignancy in these individuals. As I said, that staging of lung cancer and or assessing the suitability of surgery, it can be done in the same setting when you are doing a bronchoscopy. So bronchoscopy is very useful, less invasive modality than mediastinoscopy or any other, along with the help of the endobronchial ultrasound to stage the lung cancer or even restage the lung cancer after patient has received treatment. Then many a times you do a bronchoscopy for a symptoms like hemoptysis or a persistent cough. Hemoptysis is the bronchoscopy is done to identify the cause of bleeding, to direct the appropriate therapy, and in mild to moderate hemoptysis, the bleeding may be controlled with the local treatment, which various types of local treatment are available to control using the laser, APC, balloon tamponade, or selective occlusion of the suspected bronchus with a block catheter. So there are various ways not only you can diagnose, but also you can control the hemoptysis in many individuals. Even if the source of bleeding is not identified, flexible bronchoscopy may localize the area of bleeding, or which will help you the angiographic embolization where the operator has to stress upon, and if it is not stopping, in what area of the lung has to be resected if there is a persistent massive hemoptysis. At least bronchoscope tells you that this is the area from where the blood is coming, because many a times the lesion is on one side on the chest diagram and the CT, but the bleeding is from the other side. So it's very important to evaluate a patient before subjecting him to a surgery like procedure, that which side it is coming from. So diagnosis of the cause of hemoptysis and also evaluation of patient for invasive procedure, the fiber optic bronchoscopy is useful. But for a massive hemoptysis, I think it's a rigid bronchoscope should be done rather than a fiber optic bronchoscope, because you will not be able to see anything with the fiber optic bronchoscope with the blood all around. Then sometimes you do the bronchoscopy for persistent cough. It is the last investigations. You've done PFT, you've done CT, you're not able to find out, you've done an ENT examination, you're not able to find out the cause. The flexible bronchoscope is one of the last diagnostic modalities employed in the evaluation of patient with subacute or chronic cough. And it may occasionally identify a foreign body, a growth, or which could be a cause of cough in that particular individuals. Then of course it is done for recurrent infections, because to rule out any obstructive pathology in there in a patient who is getting recurrent infections, and you don't see on the radiology anything which is suggestive of the cause of the recurrent infections. Then there are many other indications for which bronchoscopy is done, like the suspected airway obstruction. Airway obstruction may be expected on the basis of history, like patient has aspirated, or abnormal physical examination, like you are finding a focal monophonic wheeze, or abnormal pulmonary function, flattening of the inspiratory or expiratory limb. So in those patients, bronchoscopy is done to find out the reason for airway obstruction, which may not be a neoplastic, but it could be neoplastic. So it is one of the reasons. In suspected upper airway obstruction, you do a bronchoscopy. The bronchoscopy is helpful in assessing the patency of the airways, confirming airway obstruction, and identifying the cause. And if you find any tumor or any obstruction, the ultra thin bronchoscope can be passed by the side of obstruction to see beyond the lesion, so without compromising the ventilatory capacity of individuals. So this is another way which bronchoscope or ultra thin bronchoscope could be useful. Then evaluation of a stridor is performed to find out the etiology of stridor, to determine if there is any vocal cord lesions or there is any tracheal stenosis. And the location and extent of tracheal stenosis is identified to plan the appropriate therapy. It's also performed when airway narrowing is suspected on the chest CT to evaluate what is the etiology and what is the length, as you see on the CT, to confirm the length of the stenosis with a thin bronchoscope. Then tracheobronchomalacia. The flexible bronchoscope can be used to diagnose tracheobronchomalacia by doing a bronchoscopy. If you see a dynamic airway collapse and it is obstructing almost all the bronchial lumen, you know that you are dealing with a tracheobronchomalacia. Then in a patient who had a lung transplant, it's a very good modality to find out the lung transplant rejection or infection. The transbronchial biopsies are very frequently done in these patients to diagnose the post-transplant complications in lung transplant patients. So you can obtain a bronchial lavage or you can obtain a transbronchial biopsies in transplant patients to determine the rejection and also to find out the opportunistic infection like the PCP, the cytomegalovirus or the Aspergillus infection. These are very common infections in lung transplant, so bronchoscopy would be very, very useful in these patients. Then in a patient who had a toxic inhalation or a burn injury, the bronchoscopy is done to evaluate the airways because there could be an evidence of smoke inhalation like carbonaceous debris, mucus pallor, mucus ulceration or mucus erythema. And the most important thing in a burn patient is that you evaluate the larynx. If you find the larynx is edematous and patient has a little compromise in breathing, you know that this patient needs an intubation because the edema increases so much in the first 24 hours, and if you do not recognize the laryngeal edema early, sometimes it becomes so much that intubation becomes difficult. So in a patient who's got a facial burns and you expect that patient has a toxic inhalation or injury, slight compromise, otherwise oxygenation is appearing all right, for 24 to 48 hours you must intubate these patients because once they develop frank edema, it becomes very difficult to intubate these patients. Then the other indication is the in patient of chest trauma. Sometime you do to evaluate the airways in a patient who's got a chest trauma if you suspect any tracheal or bronchial injury. Then tracheoesophageal fistula. Tracheoesophageal fistula, usually you do a gastric series, gastric imaging series to diagnose. Bronchoscopy is also done in these patients. Tracheoesophageal fistula can result from prolonged intubation, prolonged tracheostomy tube. It could be a malignant in a region. So if you have to find out the reason for this, then you need to do a bronchoscopy to confirm the site of the tracheal opening. And if you don't see, you can give a methylene blue to that patient during bronchoscopy, and it may help to identify the site of tracheoesophageal fistula. Again, the bronchopleural fistula, the bronchoscopy is very useful, particularly in patients post-lobectomy and post-pneumonectomy patients. They develop a bronchopleural fistula, may be used to evaluate the integrity of the surgical stem. And otherwise, if a person has a persistent fistula, you can block the various airways, various bronchi, and where you don't get a leak, you know that the bronchopleural fistula lies in this segment. And then you can do various procedures, gels or any other thing to close the bronchopleural fistula. Then it also used to evaluate the complications of artificial airways. Flexible bronchoscopy is performed to assess any tracheal damage or ventilation difficulties, obstruction from mucus or blood clot, ulceration, stenosis, cuff leaks. So in a patient who is on a prolonged intubation, you can do these to find out if there is a problem in the airways. It is also done to confirm the tracheostomy tube placement when there is a dislodgement or you had inserted percutaneously, because whenever percutaneous tracheostomy is done, is ideally after you've completed the percutaneous tracheostomy, you confirm the site of the tracheostomy tube. Similarly, in a patient who is dislodged and you have put in, you need to confirm that. There also bronchoscope can be used. Then it is useful in precancerous lesion. Flexible bronchoscopy, in many of these scopes there is available of autofluorescence or a narrow band imaging, which can be used to diagnose and sample the precancerous lesion in the trachea or the proximal bronchi and to determine the extent of airway involvement prior to any surgical resection. Its use for the routine evaluation of precancerous lesion in population at high risk is really controversial. But this is one of the very important. You just change the light and you're able to see the extent of lesion, whether you see by the fluorescence or by a narrow band bronchoscopy. Then bronchoscopy also has a therapeutic indications, and there are large variety of things which you can really do with the bronchoscope. Mucus impaction, foreign body removal, endotracheal tube placement, laser or argon plasma coagulation, photodynamic therapy, electrocoagulation, cryotherapy, balloon dilatation, brachytherapy catheter, tracheobronchial stent, bronchial thermoplasty, facilitation of drainage catheter placement, needle aspiration of the mediastinal cyst, treatment of bronchopleural fistula, FOB guided percutaneous tracheostomy. So there are various large number of uses, and it is emerging as a modality to treat the patients of emphysema bronchoscopically. There are a lot of intervention devices, valves, coils which can be put as a through the bronchoscope to decrease the hyperinflated lung volume and improve the lung function. So in the treatment of emphysema, it is also emerging as a modality. So I'll discuss these various indications of therapeutic in bronchoscopy. Mucus impaction, I think it is one of the very common in the ICU when the area of lung collapse and which does not respond to the chest physiotherapy. You require to do a bronchoscopy to improve the ventilation, oxygenation in these patients. And not only you clear the mucus, you can also obtain the specimens which can be sent for testing, and you can change the antibiotics if required in that patients. Then foreign body removal. As I said, the rigid bronchoscopy is a scope for taking out the foreign body, but flexible bronchoscope has now a lot of modalities which can help you to remove the foreign body from the adult's airways. And there are various kinds of forceps and the baskets which are available. There are a lot of retrievable devices which are passed through the working channel of a flexible bronchoscope, like I said, grasping forceps or baskets, which can help you to, as you can see, it helps you to remove the foreign body from the lower airways. In the ICU, many a times a patient has condition always like a very morbidly obese patients, short neck patients, or a difficult intubation. The fiber bronchoscopy could be a very useful modality, as you can see, is a useful modality to safely intubate the airways in these patients who develop respiratory failure or for any other indications. And sometimes it's even required in the operation theatre to electively intubate with the help of the fiber optic bronchoscope. It's also done to not only to introduce, but you can confirm the tip of the endotracheal tube where it is exactly lying. It should be about 4 to 5 centimeter above the carina. Then when you have to put a double lumen tube, then also the fiber optic bronchoscope is very commonly used by anesthesiologists to position the double lumen endotracheal tubes and to achieve the selective lung ventilation. Then for laser or argon plasma coagulations, a flexible laser fiber can be introduced through the working channel of a flexible bronchoscope with a ceramic tip to ablate the endobronchial lesions. ND-YAG laser, which can desiccate and vaporize tumor or abnormal tissues which occlude the airways, can be used to clear the airways in a patient who has got a tumor. Similarly, a flexible argon plasma coagulation probe can also be introduced through the bronchoscope to debulk the endobronchial mass. Then photodynamic therapy. Photodynamic therapy is provided with a flexible bronchoscope to destroy the endobronchial tumors. You give a photosensitizer drug called hematoporphyrin which accumulates selectively in the neoplastic tissue. Then through the flexible bronchoscope, photodynamic therapy probe is introduced through the working channel that emits a light at a wavelength of 600 to 800 nanometer to activate the photosensitizer in the target lesion, leading to the death of the neoplastic tissue. And then the dead tissue is usually debulked later with the rigid bronchoscope. Then electrocoagulation. During electrocoagulation, a flexible electrocautery probe is introduced through the working channel of the flexible bronchoscope. By applying current through the probe, tracheobronchial tissue or endobronchial tumor can be coagulated within the airways. And some electrocautery probes have snares, as you can see on this, to cut and cauterize simultaneously to minimize the bleeding from the removal of a polypoid endobronchial mass. As you can see on the screen, a polypoid mass is being removed with a metallic wire snares. Then a cryotherapy. A flexible cryoprobe can be inserted through the working channel of a flexible bronchoscope to destroy the endobronchial tumor or a granulation tissue. As you can see on this is a cold therapy. It can be applied to destroy the endobronchial tumor or a granulation tissues. As liquid oxygen passes through the catheter, the metallic tube of the probe is cooled, and when placed in contact with the target tissue, this causes protein denaturation, leading to the cellular death. The tissue is destroyed by repeated freezing and thawing, and it's often used to remove certain foreign bodies that have an organic content. Then there are many things which you can do through the flexible bronchoscope, like balloon dilatation. They are like you do an angioplasty. Similarly, the balloons are there which can dilate the trachea or the bronchi. You pass to the working channel and it is inflated, the balloon is inflated under direct visualization, and you do a serial dilatation from a smaller balloon to a larger balloon to achieve the best result. One can know the length of the stenosis before doing all this, either by a reconstruction imaging through the CT, or you can do an ultra thin bronchoscope to find out the length of the stenotic segment. Then brachytherapy, catheter placement. A brachytherapy catheter is introduced through the suction channel, and it can be used with the ultra thin bronchoscope, and it is put at the target lesion, near to the target lesion, and through this catheter you put the radioactive pellet, the adjacent to the catheter, to target the malignant tissue during the treatment sessions. And the radioactive pellets, they will emit high dose local radiotherapy to destroy the malignant tissue without disturbing the normal lung. Usually 3 weekly sessions are planned, each lasting about 30 to 45 minutes. Then the bronchoscope is a modality where you use it for putting the tracheobronchial stents. Expendable metallic stents and certain hybrid stent can be placed with the help of a flexible bronchoscope in the airways occluded by tumor or strictures. The stents are most commonly placed in conjunction with the ablative therapy or balloon bronchoplasty. So if there is an obstruction caused by a tumor, then you ablate the tumor. If it is a stenosis, you dilate the stenosis, and then you put a stent. Stent can be put with a fiber optic bronchoscope, stent can be put with a rigid bronchoscope. Most of the people, the prefer, who are a real interventional bronchoscopists, they prefer to put the stent with a rigid scope. And silicone stent usually require the rigid bronchoscopy. You can't put silicone stents with the fiber optic bronchoscopy. And bronchoscopy is not only useful for placement, but even if you put a rigid scope, the fiber optic can be used to clean both metallic and silicone stent, or to rule out the stent migration. Then One of the very good modality which is emerging, and I think if it is successful, many of us would be doing, and that's called the bronchial thermoplasty. We know that the problem in an asthmatic is a bronchoconstriction by the smooth muscle, increase in the size of smooth muscle, and because of various mechanisms there is a obstruction. Now, patients who are refractory to medical management, you've tried everything, patient is still suffering. In these patients, you could use thermoplasty to weaken the smooth muscles of the airway. A special catheter is passed through the bronchoscope, which has an expandable coil through the working expandable coil. So after placing the bronchoscope, you put this catheter through the bronchoscope. The coil is placed in the airways in direct contact with the wall, and thermal energy is applied to induce smooth muscle fibrosis, and this is assumed that it will prevent the bronchoscope. There are various studies which have shown improvement in the symptoms of patient, and recently been introduced in India in one of the centers. Then it is useful for facilitation of catheter placement. You know, many patients have a very large lung abscesses where you could use a bronchoscope to place a catheter into these parenchymal abscess and to administer the antibiotics locally. Needle aspiration of the mediastinal cyst. This is another use where the EBUS bronchoscope can be used with a TBNA to drain the mediastinal cyst. Not very commonly used, but this can be used in these. And then the treatment of the bronchopleural fistula. See, in patient with a persistent air leak is a problem. Before subjecting them for surgery, it is advised that you do a bronchoscopy and you find out which segment of the airway is leaking. And after you find out the segment, then you can introduce either a gel, or there are various modalities available like endobronchial one-way wall. Some people introduce gel, and people have even tried the silver nitrate in these to control the leak. Then the bronchoscopy is now very helpful to a pulmonologist to do a percutaneous tracheostomy, because it's a safe, and many of the centers and many of the ICUs, the percutaneous tracheostomy is being done by the pulmonologist with the help of the fiber optic bronchoscope. As I said earlier, the role of bronchoscopy in the management of emphysematous patients who are really suffering very bad, it could help the bronchoscope to introduce the one-way wall or the coils in managing emphysema as a mechanism of lung volume reduction surgery, because it's a non-invasive lung volume reduction which you can do through the bronchoscope by introducing the coils and the one-way wall. To summarize, a large therapeutic indications: mucus impaction, foreign body removal, endotracheal tube replacement, laser or organ plasma coagulation, photodynamic therapy, electrocoagulation, cryotherapy, balloon dilatation, brachytherapy catheter placement, tracheobronchial stents, bronchial thermoplasty, facilitation of drainage catheter placement, needle aspiration of mediastinal cyst, treatment of bronchopleural fistula, FOB guided percutaneous tracheostomy. So we have very large number of therapeutic indications. So as in the last half an hour I've told you that there are a very large number of indications of bronchoscopy. It is like a stethoscope for a pulmonologist. So it's extremely important not only to acquire the skills properly, which are not only safe, which are good for the patient, and they are more diagnostic. So it's important to acquire the skills of fiber optic bronchoscopy and preferably also rigid bronchoscopy. Thank you very much.